Hi, my name is Dellon. I'm one of the adult gastroenterologists at University of North Carolina School of Medicine in North Carolina. Today it's a pleasure to speak with you and provide a physician introduction on eosinophilic esophagitis. These are my disclosures. And for the talk today, this is the overview. I'd like to help define what is eosinophilic esophagitis and specifically talk about symptoms, the endoscopic findings, and the histology that lets us put it all together to make a diagnosis, then discuss some common EOE treatments and review the long-term approach to EOE. So before we talk about the condition, I'd like to talk about what is an eosinophil. So an eosinophil is a white blood cell, and this is a smear of all the white blood cells in the blood, and there's the eosinophil in the top right. And it's one of the kinds of white blood cells that is normally detected in low levels in the blood, and it has a main role of fighting infections. Now, importantly, we never see the eosinophils normally in the esophagus, though you can see them in other parts of the GI system. When we think about the functions of the eosinophils, here they are, the schematic. They have a central function where they not only respond to different stimulations like infections and tissue injury, but also have a role in allergy. And they can talk to other immune cells, like things called T cells and mast cells, and they can secrete or release a number of factors that cause inflammation. And that's where they can lead into both a normal response and into allergic troubles. So what is eosinophilic esophagitis? Well, we have this conceptual definition that EOE represents a chronic immune-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil-predominant inflammation. And let me just unpack that. It's chronic, which means we don't have a cure, and it is a long-term condition that's not self-resolving right now. It's immune or antigen-mediated, which means it's an allergic process in most people. On the clinical side, you have symptoms that I'm going to talk about. And then when we do an endoscopy and take biopsies to confirm a diagnosis, we can see under histology or examination under the microscope that there's a lot of eosinophils there that shouldn't be there. When we think about the clinical presentation of EOE, we think about symptoms primarily. And in adults and adolescents, dysphagia, which is the medical word for trouble swallowing, is the most common that we see. And in fact, if people have a lot of troubles with this to the point where food actually gets stuck in the esophagus and they have to go to the emergency room, more than half of the time in that situation, EOE is the cause. But it isn't just a sensation of food sticking or choking. It can be a sensation of food going down slowly or something that's subtle where people might modify the way they eat by eating slowly, avoiding certain foods, taking small bites or chewing foods to mush, or drinking lots of liquids to help clear the food from the esophagus, or even just worrying about symptoms when they go out to eat. Some people can have heartburn or even chest pain with EOE, and this is sometimes a cause of what would be refractory reflux, reflux that isn't getting better with standard antacid treatments. And rarely in adults would you have abdominal pain, nausea, or vomiting. But in children, symptoms are quite different, and they could range from failure to thrive, to feeding intolerance, to heartburn or reflux, abdominal pain, nausea, vomiting, or regurgitation. So much more non-specific symptoms. Now, when you do have those symptoms, it tends that we need to do an endoscopy to evaluate what's going on. And this is the view of a normal esophagus on endoscopy. So we're looking down into the esophagus with a light and a camera. And you can see here it's a very smooth, healthy pink color with lots of little fine blood vessels. And this is the normal appearance. In contrast, in EOE, there's a lot of endoscopic findings. The top left picture here is actually of a food bolus, a piece of food that's stuck in the esophagus, and an emergency endoscopy is needed to clear it out. These are some esophageal rings and signs of scar tissue. This is a very narrow scarred down esophagus with scar tissue. And then here you can see a much more inflamed and swollen esophagus. You don't see those normal blood vessels, and you see these furrows, which are almost these train tracks that go up and down the esophagus. And then these are exudates or white plaques that can coat the esophagus. And here you also see rings and some furrows and some swelling as well. The lining of the esophagus also tends to be a little delicate in this condition, and sometimes passing just the scope can cause a small tear or fragility of the lining of the esophagus. Then, once you have those findings, we have to take biopsies. And this is what it looks like. This is a small biopsy forcip that's advanced through the scope. It takes a small piece of tissue and just leaves a little indentation here where the biopsies were taken in this patient with EOE. And you can see that these are very small, just a millimeter or two in size, and they heal quite quickly. Some people can be sore from biopsies. And then when you look at those biopsies under the microscope, this is what you might see. This is a small piece of the esophagus, and it shows EOE. This is the surface of the esophagus, so inside the tube, and this part of the esophagus is inside the body. And first of all, you can see all of these bright red eosinophil cells that really jump out at you. But you can also see lots of deep purple cells. This is called basal zone hyperplasia, where there's an expansion of additional cells. You can see space around the cells indicating impaired barrier function. And you can see some scar tissue here at the bottom underneath the top layer of the esophagus. Now, if we zoom in on this circle area, here's a close-up of all of these clusters of eosinophils called microabscesses. And you can see that some of the cells here have actually even released all of those granules, those pro-inflammatory granules. And so they're causing a lot of inflammation and trouble in this particular biopsy specimen. So when we think about the diagnosis, we put all of that together. We have the clinical symptoms here that are suggestive of EOE. We do the endoscopy with the findings. We see the biopsies and have to count at least 15 eosinophils to think about the diagnosis. And then we make sure that there's nothing else going on that could be responsible for an EOE for eosinophils in the esophagus. And then we can make the diagnosis. We also think about EOE as an evolving or potentially progressing disease where it starts with a lot of inflammation with the eosinophils and other cells, and then over time that might lead to scarring. It's otherwise called fibrosis. And the fibrosis is really what gives you the trouble swallowing symptoms in adults, as opposed to the inflammation giving those other symptoms that I mentioned in children. And this may indicate that you have to do more stretching or dilation of the esophagus in adults. Well, why do we treat EOE? Well, we do this to maximize nutrition, help with normal growth and development, minimize symptoms and improve quality of life, help the esophagus look normal and healthy, help the biopsies look normal, and then to prevent complications that are due to this kind of scar tissue like strictures, food getting stuck, or even esophageal perforation where the esophagus can tear. Right now, we do not believe that that EOE is a risk factor for esophageal cancer. We don't think that it progresses to a cancer, which is good news. Now, switching tacks for the last few minutes just to the current EOE treatments. We have both treatments that are non-pharmacologic that don't involve medications. This is diet modifications or stretching the esophagus, and some treatments that involve medications. And there's a long list of different medications that you can use. Unfortunately, we still don't have any medicines that are approved for EOE treatment in the US by the FDA, but there is a topical steroid medication that is approved in Europe and Canada. And I'm going to talk briefly about some of the medications, including the proton pump inhibitors, the topical steroids, and then some of the non-medicine options, including the diet elimination and dilation. So proton pump inhibitors, or PPIs, are medications that you may have heard about. Some names include omeprazole or lansoprazole or pantoprazole, among others. These are typically thought to be heartburn and reflux medications because these meds have a strong anti-acid effect. Well, why do we use them in EOE? Well, it turns out they have good response rates, maybe 40 to 50% of the time. They will decrease the inflammation with the eosinophils and make people feel better. And it's important to realize that if these are prescribed for EOE, it's not really for their anti-acid function. They have an anti-allergy effect that works differently in EOE. They block an allergic factor that seems to bring the eosinophils to the esophagus, and they help improve the esophageal barrier and make it less leaky. So these are often one of the initial medicines that are used. Topical steroids. So what's the concept here? The goal is to coat the esophagus with an anti-inflammatory medication. It's sort of like putting an anti-inflammatory steroid like hydrocortisone onto a bug bite. You rub it and take away the redness and irritation. And since we don't have any approved medications right now, we're adapting asthma medicines and asking patients to swallow rather than inhale them to coat the esophagus. And some medications that are used may be fluticasone, where you puff an inhaler into your mouth and swallow it, or budesonide, where you may mix a liquid into a syrup and swallow it. These are taken every day and are quite effective for decreasing eosinophils in the esophagus, improving symptoms, and improving the endoscopic appearance. And within the next couple of years, if not sooner, hopefully there will be approved esophageal specific medicines. So medicines designed for the esophagus, not for asthma. And in fact, one of these medicines is what's approved in Europe and Canada. Next would be dietary elimination therapy for EOE. Why do we think about this? Well, in most people, EOE is a type of food allergy. And if the food triggers can be found and avoided, this is a very nice treatment. There are generally three overall strategies. There's for very ill patients or for babies, you can use an elemental formula, which has no allergens in it at all. And that can be very helpful, but it's not very practical for longer term use, particularly in older kids, adolescents, and adults. You can use what's called the 6-food elimination diet or another empiric elimination diet. That removes the foods, the top 6 or so that are seen here: dairy, wheat, eggs, soy, um, nuts, and seafood, and that can also be effective. There's different varieties on this, so not as many foods would be eliminated. And then there's what's called the targeted elimination diet, which isn't used very commonly anymore, where you eliminate foods based on allergy tests. And that's because our current allergy tests aren't very accurate to identify food triggers in EOE. Um, so that's one of the real downsides of this kind of therapy, and it can be difficult to stick with the diet. But the overall goal is to eliminate a number of foods, and then with endoscopies and with the care of your doctor, add one back at a time and assess whether that individual food is a trigger. And then serially add back all of those foods until you know what the set of triggers would be. Last, I'd like to talk about esophageal dilation. Now, this was used if you do have a stricture or narrowing in the esophagus and the esophagus has to be stretched. You can see here in these pictures a very narrow esophagus. This is a balloon catheter that's placed through the camera. The balloon is blown up, and you can see this dilation effect where the esophagus is stretched. And this is the goal. This is not an adverse effect or a worrisome tear or perforation, but this is the stretch of the esophagus that allows it to be a larger caliber. From my standpoint, it's important to use the dilation in conjunction with other treatments that are getting rid of the eosinophils, because this is just a mechanical treatment, and you need to do something to treat the inflammation as well. Now, there are a lot of new treatments on the horizon, and actually, if you look on the clinicaltrials.gov website, there were more than 35 active or planned clinical trials that are ongoing. These involve things like the custom-made topical steroids for the esophagus, a number of biologic agents that are targeted at factors that we think cause EOE, and some small molecules that also may be targeting factors that we think cause EOE. So it's a very exciting time, and a lot of new treatments are on the horizon. When we think about monitoring EOE, because it is chronic, we have to check you out over time and keep an eye on the condition. And we monitor in 3 different areas. As you might guess, since I've talked about them: the symptoms, the histology and how the biopsies look, and how the endoscopic activity is. And so these are reflected on these scales. And each one of these can be independent of the others. So you might feel better, but the esophagus and biopsies may not look as good. Because of that, we can't monitor symptoms alone. We do rely now on monitoring symptoms and an endoscopy with biopsy at the same time. Over the long term, ongoing care and follow-up are needed. The condition does not go away by itself. Treatments should usually be continued in most patients because we know if they're stopped, the EOE will flare. But treatments can change or be adapted over time, so a single treatment now is not a forever treatment for you. And then we monitor treatments with clinic visits and endoscopies. So in summary, EOE is a chronic allergic condition that causes a wide range of symptoms that are due to both inflammation with eosinophils in the esophagus and scar tissue deposited in the esophagus from the inflammation. There are multiple effective treatment approaches, so talk to your doctor about which one might be right for you at the current time in your life. Long-term treatment is required for nearly everyone, and the condition needs to be monitored long-term, but multiple new treatments are being developed. Now, I'd just like to end by pointing out this patient registry website that I've helped to found with both researchers and patient groups. This is a global patient registry that focuses on patient-centered research. And so please check it out and join if you're interested. Thank you so much for the opportunity to speak today.